I remember sitting outside the office of the doctors with my dad, seeing these names on the door, and then here they were with projects that I could do with them. So I was kind of like, okay, this may be what life's calling me to do.
You wrote a paper that I read just last night. Is sleep the new treatment for pain?
Most of us can relate to, I was sore, I just didn't sleep last night because I was sore. But actually the evidence is becoming very clear that poor sleep can make your symptoms worse. And it may be a bit controversial to say this, but maybe we try fixing sleep before we look at exercise. And that's what our trials are at the moment, to see if we can get better effects when you do the two together.
This podcast is not personalised medical advice. Consult a health professional before acting on anything discussed. Just give me 30 seconds before we start. Whether you're a clinician wanting better outcomes for your patients, someone living with chronic pain, or supporting someone who is, thank you for being a loyal listener. Most regular listeners haven't hit follow yet. If that's you, please tap it now. It tells the algorithm to show this to more people it can help. And that's the single biggest thing you can do to help me and my guests on our mission to create a world with a little less pain.
Michelle, it's been a bit of an Irish takeover on the podcast lately. I had Merv Travers, and then I had Neve and Barry from Curtin University, and now yourself. What is it about the Irish that leads them into research?
Yeah, it's a great question, and thanks so much, Lachlan, for having me on your show. I growing up in rural Ireland, I never knew about research. I never really knew it was a pathway at all until I went to university in Dublin, and I did exercise, sports science and health, it was called at the time. And funny enough, my mentor, the head of school at the time, we found out afterwards that his father used to deliver chicken meal to my grandfather on the farm. And he was really, really kind to me. And he had me an honours project with a couple of other students with a surgeon who had done my dad's knee replacements and my granddad's knee replacements. And I just, as they say, got the bug with the research. You very rarely find all the answers that you want, but you find enough to keep you coming back and wanting to know more. And yeah, so he said I was walking around like a Cheshire cat. So I suggested that I keep going with the research pathway. And I was pretty intimidated by a PhD. I was like, oh no, I'm not fit for that. I'm not ready for that. And so he's like, go to the US, do a master's. And he wrote out a list of all these unis at in the US, and I picked out Iowa. And he was like, I come back in on Monday, and he's like, why did you pick out Iowa as the armpit of America? And I was like, I thought it was kind of the one that maybe would feel the most like home. It was kind of small, rural, relative to some of the bigger cities. But I was fortunate enough and got a place there and did 2 years in kinesiology program and absolutely loved it. Really, really did. And as I say, my love for research just kind of kept growing, and I was fortunate enough then to get a PhD position at Melbourne Uni, where Professor Kimbinell was leading research programs around osteoarthritis, knee osteoarthritis, and just pulling off these amazing trials, like fantastic, around exercise, how exercise could help people. No problems with recruitment, which was something I was struggling with my little master's project. So I was very, very fortunate and spent the time in Melbourne until about 3 years ago. We moved to Sydney.
Yeah, cool. Awesome story. Tell me, was there something about your dad and granddad's experience that led you into sort of knee osteoarthritis kind of research area?
100%. So I went into sports science, sports mad, right? I loved all the things about sports. And kind of as you went progressively through the degree, you realize that, exercise science, exercise physiology, biomechanics, you could actually help a lot more people than the elite sports people, as attractive as that is. And so when the honours projects, the professors kick up different projects. So when the one came up around osteoarthritis, and I knew it was in association with Kappa Hospital, I was like, okay, that's the one I want to do. Because I remember sitting outside the office of the doctors with my dad, seeing these names on the door, And then here they were with projects that I could do with them. So I was kind of like, okay, this may be what life's calling me to do.
Yeah, that's awesome. And was there, your dad or your granddad's journey, was there something that you were like, man, we're not doing this well enough? Or was there a curiosity, or what was it that kind of got you thinking, oh, I'd love to go down this pathway?
Yeah, like it's interesting you say that. And I think it kind of happened reverse for me. It wasn't like when I was growing up, my dad was diagnosed with osteoarthritis quite young, so he had his joint replacement in his 30s. So he was farmer, as my granddad was. So, definitely in the case of my dad, it really was tough for him. He was very frustrated that he couldn't do the things that he felt he should be able to do as a young man, and to do things with the kids, and he'd be really sore, and there would have been days I was off school because I get to help him, which, I loved as a real daddy's girl. So but it never was like, oh, I want to do something to fix this. I never really thought that I could, or never saw myself in those positions that I could help people like that. But I think growing up and being exposed to that, I can really, I can relate, especially to people with lived experience. I can relate to the carers or the people around them and how much it actually does affect families. And I think, yeah, it was really tough at times for him, especially like during those really acute pain periods, and at that time it took maybe 2 weeks to get a joint replacement. So you had to figure out how to make everything else run while, at the same time. And, obviously my mom was a great support at that. But so then when those opportunities came up that you could do research in this space, oh, maybe there are things I could do to help. And it was kind of like marrying these two areas that I loved: exercise, sports, and then, you kind of got the passion that you've seen and the area where you could apply it.
Yeah, interestingly, I kind of share that with the sport idea, because like when I was studying physiotherapy at Griffith here, I actually, in my last year, I was a sports trainer for the Gold Coast Suns, the AFL team up here. And I thought, oh, this is exactly, this is what I want to do. And then being around it for a while, I was like, maybe it's not actually. Maybe the trade-off of the travel and etc. is not worth it to help people run a little faster or jump a little higher. And the impact that you can have on a life is, in my opinion, far greater in other areas of physiotherapy, and it sort of led me away from that. But yeah, interesting. I share that passion, and then I've sort of drifted elsewhere throughout my career. I've noticed that your research has taken a bit of an arc, or like there's been a bit of a trajectory, initially with biomechanics, how the knee loads with certain movements, etc., and then more to some of these bigger picture things, whole person, sort of complex systems approach into sleep, which I think we'll hopefully hone down on a little bit. But how did that? Tell me what led to that sort of journey.
Yeah, and I think it has been a bit of a journey. So biomechanics always kind of just made sense to me. I mean, it made sense. Okay, you've got a sore knee, you load it. It's sore when you load the knee. It should be quote unquote fixed. If we can get the biomechanics right, it can fix it. And that's where I did my PhD on exercises that are maybe similar, maybe to some of your listeners have heard, around the GLAD program. So we did some. The trial was really to see if exercises could reduce the loads across the knee when somebody walks by doing these exercise programs. And like, for the want of a better word, absolutely saw zero change. Like, just like when you put everybody together, the average was zero. We did not change one aspect of biomechanics. And yet people felt better, people reported to be better. But that was like, okay, of course there's other things to it. But to do biomechanics research is actually a huge effort. It's monumental relative to some things that we can check off by questionnaires. Like, people come into the lab, they get all these markers put on them. They're in the cameras, the equipment, the process, and it's just a very, very, very involved. And it just kind of became, I started to doubt whether the juice was worth the squeeze, so to speak, because of the effort. And then in that sort of transition of questioning the role, and, can I really justify putting this biomechanics research? I don't want to poo-poo all over biomechanics research, but can I justify spending all this grant money and effort into this when I just started to really question, at least on the average populations, was it really worth it? I think definitely for some people, biomechanics is the focus. And at that point, I had 2 kids, and the second was not a good sleeper at all. So I was really struggling with sleep. And I was talking to my friend and colleagues from University of Queensland, David Klein, and he was like, we were just having a bit of banter, and he was like, well, keep exercising, because, your exercise will offset the effects of bad sleep on your body, right? I was like, oh, okay, it's hard, David, but okay, thanks. So he started telling me about his research in animal models that was fascinating. When they exposed these animals, they kind of gave them an injury, and then they exposed them to disturbed sleep, the wheel and the cage, so exercise, and then both. And yeah, those animals that had been exposed to the exercise or the opportunity to exercise, that it offset the detrimental effects of the disturbed sleep on their transition to what we'll say chronic pain in an animal model, where they don't want to put their foot down because they want to avoid paws of foot ground contact. So that kind of stuck in my mind a little bit. And then I started to dig around in the sleep literature around insomnia. So that's kind of the difficulty of falling asleep, staying asleep, and waking up early. And when we pulled out the studies that had done cognitive behavioural therapy for insomnia, which is kind of like the first line treatment for insomnia, in these chronic musculoskeletal conditions like osteoarthritis and low back pain, lo and behold, we were seeing effects similar to what exercise gets by itself. So, and then, it kind of started to make sense as well, in the sense that these exercise and sleep disturb the neuroimmune system, and they probably have synergistic effects. So that sort of started that trajectory. And then, yeah, we were fortunate enough to pick up some grant funding in this. So this is kind of the path that we're on now.
No, it's cool. I'm not surprised that well, it is tricky to pick up grant funding, but because knee osteoarthritis and hip osteoarthritis is such a big problem, I can see why they would want to put some money into it. What is, because I know most of your research is around knee osteoarthritis and hip osteoarthritis. What is osteoarthritis, for those that are listening going, I've heard this term, but what actually is it?
Yeah, it's a really good question, and one that's probably a bit misconceived out there. Essentially, it would, and there's different definitions, but I'll give you the one that I think is probably more clinically, and maybe your listeners can relate. So it's this idea where you'd maybe describe that you've had chronic pain, so ongoing pain for 3 months or more. And you might have it on most days, not every day. And we know pain is very variable for everybody, and that it does impact your ability to do function for everyday activities. So you do feel it when you walk, or you do feel it doing stairs, or maybe getting out of the car. So it impacts. And then there's another, let's say, criteria is that, your stiffness doesn't last too long. So stiffness, if you do have prolonged stiffness, it may indicate something else. So that's why they have that in there as part of the criteria. A lot of people think, oh, I need to get an x-ray or I need to get an MRI. Really, the narrative, the push is in this space over the last number of years is that you don't necessarily need at all to get an x-ray to confirm this. And what's really interesting is that what people see on an x-ray and or MRI does not correlate very well with how people feel. And, you might have the most pristine knee on a beautiful x-ray, right? But you feel crap. And then that doesn't make sense. It doesn't really validate that feeling for you. Like, well, why am I feeling so bad if the joint looks so good? And then vice versa. We've had this a lot of times where we've had participants come in and say, oh, I've seen my x-ray, it's bone on bone, and that's it, right? And then there's this when you see like bone on bone, I think it's very hard to remove that from your mind. It's very hard to go, okay, well, I'm going to do my exercises, or I'm going to follow the advice of the professionals, because you've seen, you know, it's sort of really valid. Okay, that's why I feel the way I do, because it's bone on bone. But honestly, how you feel is so different can be so different to what we see. And sometimes I think it's a bit like our teeth, right? A teeth can look great and you might have a toothache, and vice versa. You know, your tooth might look pretty crap, but so far so good, you know?
Mm. Yeah, I had a client come in and had right knee pain, but on X-ray it was, you know, mild, and on the left it was severe, and he had no, or it was moderate or something like that, and
Yeah.
had no left knee pain, and it was, you know, like I expect that between individuals, but then within the individual, even
Yeah.
there was no clear relationship between the amount of, and I had to like double check. I had to look at the X-ray twice. Have they labelled this correctly as his left
Yes.
knee? You know,
Is it
and
the right person? Yeah.
yeah,
Yeah.
it is wild. And I think most people, well, at least the general public listening, would be surprised by that statement. So what else is going on then? Why is that the case? If it's not, because I think we've shifted from it's all about the X-ray, it's all about wear and tear and damage to something else. What else is going on that could be contributing to that pain?
Yeah, and this is where I'm going to get very boring on you, Lachlan. It's kind of this is the classic answer. It depends, right?
Yeah, yeah.
There's so many things that can be going on for that individual, right? So we really now appreciate osteoarthritis is not just focused on that joint, as you mentioned earlier. It's the whole person. So you know we've done some work that suggests that there are changes in the brain, you know, and it's how you process that feeling. It can be a lot of it can be driven by inflammation as well. So there's a big shift on neuroimmune markers, inflammatory, and it's an interesting space because people think, oh, is there just one or two markers that can sort of maybe identify or predict, or you know, can we use these markers in bloodstreams to really target treatments? But we're not there yet, because it's almost like a constellation of markers, and we don't know what that perfect constellation is and for who. So I think you know, there's a mental component to it, and for some people it is biomechanics as well. You know, some people really feel that pain during activities, and then some people will really feel it at night. Um, and it's quite complicated, and I think this is probably why the field has struggled so much to come up with, you know, really consistently effective treatments.
Mm. Yeah, I love the nuance there. I think in my mind there's two broad types of pain. There's like the pathoanatomical pain where there's, you know, structural damage and it's still healing, etc. But then there's also this pathophysiological pain where there's changes in the way the body systems are interacting that can, you know, lead to inflammation and things like that. And I wonder whether, if you had to put your, you know, flag somewhere, would it be more the, you know, the structural side for you when it comes to knee osteoarthritis, or would you say that it's more about you know, these changes within the body systems, or is it a combination of the both? I think I know what your answer is going to be.
I think it starts out the former. You know, I think there's something that, you know, a lot. So one of the biggest risk factors to develop future osteoarthritis is a knee injury, and also being overweight and being a woman. So I think for a lot of people who've had a knee injury, it is that initial change. There's something that's happened that maybe sets off a cascade of interactions that we don't really fully understand yet. And then at some point, and I don't know when that point is, it probably does transition to the latter, where it is more of a systems involvement, and it's really about for the scientists to really figure out when that happens and who it happens to, so we can prevent. Because I think right now we're quite reactive and not proactive enough to get ahead of this. We probably do know enough right now for prevention, but it's hard to roll out those programs, you know. And weight loss is a big one, or managing your weight is big, as especially when you've had the injury. I think it's really important.
What are some common myths when it comes to osteoarthritis of the lower limbs, knee and hip?
Yeah, I think people think, oh, if I exercise, I'm going to make it worse. Unfortunately, I think, as I said, we've said, you have a look at the X-ray, and if it just doesn't marry up, right? You've got a bone on bone, and yet this guy is in front of you, a girl is saying, "Oh, go exercise." You're like, but that is actually the sure thing we do know. You're much better to keep moving. Um, I think we're still getting a handle on how much you need to do, and that how much will unfortunately depend again on individuals. But with wearables now, I think we're positioning ourselves to get some answers to that, with the use of the watches, how much you're actually doing, the types of exercise you do, and the intensity. There's some trials going on at the moment in Denmark around high intensity exercise to see if that's maybe a little bit more effective, because generally right now aerobic exercise seems to have the nudge, especially when you compare it to, let's say, nothing or usual care or no treatment. But when you actually compare maybe aerobic exercise to neuromuscular exercise or to mind body, there's no difference between the types of exercise. But at present, it seems to be aerobic. Well, we did a study last year, so there's much more information out there about the knee than there is the hip. And traditionally, we've sort of take evidence from the knee and we go, okay, well, it's close enough. Let's go with the hip. And unfortunately, it's probably not a good. You do it because you have nothing else to go on, but we need to be more cautious with that. And last year, we published a study where for this is specific for hip osteoarthritis, where we had kind of seen that most of the evidence was for resistance exercise, so strengthening exercises around the hips and knee muscles. And we added the public health guidelines to get up to 150 minutes of at least moderate exercise, moderate intensity exercise. And we were really pleased to see that physios were amazing to support people to do that and coach them essentially. But there's no difference between the two types of exercise programs. So doing more didn't get you better pain relief or didn't get you better function improvements. But the fact that you could still do it without having more unwanted effects, if you like, was encouraging. And also we know that there's benefits of doing aerobic exercise above and beyond resistance as well. So from that point of view, it's good. But if you've got somebody in front of you that really wants more improvement in terms of their hip pain and function, it didn't seem to achieve that.
Yeah, this is a common theme when I talk to people that have knee osteoarthritis or hip osteoarthritis, is this idea that, but if I do more, it's only going to get worse and wear and tear and deteriorate the cartilage in the joint. What is like that is our old understanding, and I think research has sort of taken us, and that always takes a little longer to get to practice and then to the general public. So what is our new understanding of I think we've sort of touched on it, but what is the new understanding of what's going on with osteoarthritis?
You definitely need movement and load to stimulate the health of the cartilage. So there's like what we call maybe a Goldilocks point. So we know doing nothing is not good, and we know doing probably too much, and you'll feel it. That's what pain is. It tries to protect you. It's not necessarily a bad thing. But you definitely need to do some to maintain what you have. And particularly when we think of who osteoarthritis affects more, so it's more women, it develops after 45, typically after 40, it can be earlier, but that's kind of when our bodies change anyway, and we really want to keep what we have, if not build on what we already have. So definitely this myth of doing more is bad is not the case for our joint. There will be a sweet spot.
I've heard that osteoarthritis is becoming more of like a metabolic syndrome.
Yeah.
Can you explain what that means and what that might mean for patients?
Yeah, no, it's a good question. So, as we kind of alluded to, knee osteoarthritis and maybe even hip osteoarthritis got a lot of attention biomechanically. But one of the other places osteoarthritis affects us a lot is our hands. So And, our hands are not really weight bearing. They don't take the loads like our hands do and like our knees do and our hips do. So I think this really where that question around what's the metabolic role in this. So when we say metabolic, it really means our lipids, our high blood pressure. I don't know all the criteria for them. But essentially it's that cardiovascular, cardiometabolic systems and that interaction again with neuroimmune markers that really elevates that inflammatory response. And we know elevation of these pro-inflammatory markers can sensitize the nerve endings and play a role in that. So it's definitely that we might call it a phenotype that specific researchers are looking into because of that. And, it's quite exciting at the moment. There's a lot of very effective weight loss strategies out there, and they are getting good results in terms of pain in osteoarthritis population. So it kind of just proves the point that there is a metabolic role in osteoarthritis, and that might be managed very well by weight loss. But I think we got to be real careful when we do the weight loss that we do the exercise as well. We don't want to lose muscle. We want to keep our muscles.
Yeah, it's interesting because there would be an argument that if you lose weight from sort of a biomechanics perspective, you're going to reduce the load on, say, the knee, and therefore that's what's helping the pain. Yeah. Would it just be that, or would you say that there's something else going on that's?
Yeah, no, it's a really good question. I'd love to answer academically. I don't think we actually know the answer to that. So there's different types of study designs that you can do to answer that causal role of doing. So there is some stats out there I forget what they are, to be honest, but you lose X amount of weight and you reduce the load of your knee X amount. But whether it's that amount that actually correlates to your improvement, I suspect that it accounts for a proportion of it, but the other part is through the other benefits of losing weight loss on your inflammatory system. And we don't know that relative to proportion. But it's a really good research question.
Yeah, for sure. Are there people looking at it at the moment?
It's a hard question. You need certain data. To be honest, probably the only people that I could think that have the data for that it's in the US, Steve Mezia. He's got good data that can answer that. And he has done correlation studies, but I don't think he did the causal analysis, as far as best my memory is, to tell you the proportion that would be mediated or improved by reduction in the loads across the joint. It corresponds to pain.
Yeah, fascinating. Tell me about sleep. What is it that you've obviously gone down that pathway when it comes to research? I am, for those that know me, and Pain Coach, which is a clinical support tool that I've developed. It looks at sleep as one of the factors that can contribute to pain. So there's my biases on the table.
Yeah.
But why do you think sleep's so important, and what role does it have in musculoskeletal pain?
Yeah, I think it's really interesting because sleep is one of those things that most of us can relate to. And most of us can relate to feeling pretty ordinary after a consecutive maybe number of nights poor sleep, even after one sleep, right? Some of us can feel that. So in terms of where this comes into pain, we know that people are more sensitive to pain the next day. So you're more irritable, you're less likely to engage in your daily functions, less likely to engage in your exercise. So it's this, again, response when you don't sleep, you sort of build up, let's say, for the want of a better, waste, and your brain doesn't wash it out overnight, and it builds up, and this increases the inflammatory markers in our body that, again, sensitize the nerve endings. And this is how we think this is one role, how sleep can really impact musculoskeletal pain. But I think it's really a biopsychosocial as well, because you got the social aspect where it's just kind of alluded to, where you kind of avoid And we know that avoidance of doing things is not good as well we feel more stiff. It's not good for our function. And then, mental health is a massive component. I think that intersects between sleep and musculoskeletal pain. Most people with sleep problems will have, I would say most, that's probably a bit harsh, but a lot of people who maybe have had sleep problems for a long time will be mentally not as clear as they could be. And there's about 20-25% of people with osteoarthritis who would have mental health problems, like things that would struggle with anxiety or maybe depressive symptoms. So that further compounds that when you don't have good sleep.
Yeah, it's interesting that. So, are you suggesting that it's not just that pain reduces the sleep, because often people in pain, they do struggle to sleep, but that sleep itself actually may directionally change pain?
Yeah. No, and thanks for picking that up. Exactly what you said. Most of us can relate to, oh, I'm sore. I just didn't sleep last night because I was sore. But actually, the evidence is becoming very clear that poor sleep can make your symptoms worse over a longer period of time. And this is maybe where I was getting at earlier. You want to kind of get ahead of this. So, just being aware that your sleep is a huge predictor is actually wild right now. Like, there's data coming out left, right, and centre about how it's predicted to your mortality. It'll actually kill us earlier. Your mental well-being. It's not just musculoskeletal, but it's a whole gamut of overall health. And we've probably not taken sleep serious enough. Like, we've, at uni when we went through, it was obviously exercise, diet. But I think more and more sleep is being recognised as that third pillar for overall health, and being really protective of it and mindful of it and disciplined about it the same way as we, if we can get into that groove around regular exercise, that's the same kind of approach and consistency that we need around sleep as well.
You wrote a paper that I read just last night. I think it was an editorial or something like that, but is sleep the new treatment for pain?
Mm-hmm.
Tell us about that paper, and yeah, I'd love to know your answer, as I'm sure most people will.
Yeah, a lot of that kind of stemmed from this observation that when we took trials, so studies that had lots of people, like trials or randomized controlled trials are kind of like our gold standard to say X causes Y. And when you took those studies that had looked at people with chronic musculoskeletal conditions, and you see the effects they're not amazing, right? They're still what we call modest. We'd still love to see better effects, of course we would, but they're the same as exercise. So if exercise is our first line treatment for these musculoskeletal conditions, and at least when we looked at these studies and we see that sleep does the same, maybe we start to manage our sleep and try to get people back on track, and get people back on track with their sleep might actually help with their commitment to be able to do exercise. So I think that's it's maybe a little bit provocative that sleep could fix it. And I think this is, what we kind of talked about already. It depends, and it's very multifactorial pain, that experience. But I do think that, managing somebody's sleep will help them a long way to manage their pain. Because the other things about sleep is that when we don't sleep long enough, when maybe people are up early, you do actually consume more, you tend to eat more. So it affects your body mass and your weight. It's sort of this full loop circle. You're less likely to exercise because you're more fatigued. So it is all connected, if you like. And one of the things I'd love to do right now is to actually look at that. If we started maybe with managing sleep before we look at exercise, because sleep is quite nuanced in that the cognitive behavioral therapy for insomnia, it seems to work, quote unquote, for maybe 60% of people within 8 weeks. And that is not a long time. Like 8 weeks, if you could fix your sleep in 8 weeks, that's pretty good, right? That's not a long time. And trying to empower people with the tools that, if you go through a slippery slope, you can get back on because you know what to do and what to manage it. And then sort of use that empowerment then to build on maybe exercise. And it may be a bit controversial to say this, but maybe we try fixing sleep before we look at exercise. And that's what our trials are at the moment, to see if we can get better effects when you do the two together.
Yeah, that's awesome. Watch this space. I'm excited to see the results that come.
It's going to take us a while at the rate we're going, but we'll get there.
Yeah. Because I use pain coach myself with clients, and correlations come up. Okay, well, it seems that when you sleep poorly, your pain's worse, or things like that. But then the question often is like, which of these things that we can see is correlated to your pain, which of them do you feel like you have power over to control, to change?
Yes.
Which is sometimes tricky when it comes to sleep. And I think there's probably people listening thinking, yeah, look, I know my sleep's bad, but I don't know how to improve it. And then the whole point of like that just stresses them out, and then their sleep, it probably exacerbates the thing. What is it about CBT for sleep? What are the, like, because I'm sure many people don't know what the ins and outs of that treatment is. Can you take us through that? Like, what should people do if they are struggling to sleep?
Yeah, so there are apps out there, right? So for cognitive behavioral therapy, and just by way of disclosure, I'm not a psychologist, and this is where this treatment comes from. It's really psychology. But people there's sort of two main components that seems to be the most effective, if you like, when you talk to the psychologist. And we have this brilliant lady, Susan McCurry from Washington, helping us with this. And she's done this in lots of different populations, like cancer patients with kidney failure, like the whole gamut. So it's bed restriction is pretty powerful. So I'm not sure if maybe you got some parents listening, but being consistent with bedtime is a big thing, same as it is with a kid. Going to bed at the same time when you are tired. And the whole thing is to really associate the bed with sleep, right? So you're not in there lying on your phone. That's a big no-no. So the bed is literally associated with sleep. So while you're trying to get back on track, you really want to, go to bed when you're tired. So for some people that start off, they might actually have their bedtime window shortened drastically. So to make sure that they're so tired, they're so ready for bed when they get to bed. So it might be like 12 o'clock, like I've seen some people, and they might have to get up at 6. So it's really condensing that window that you're in bed is for sleep. And if you can't, so for some people wake up in the night, whether it's for pain or, sometimes we wake up thinking about things. And if you can't get back to sleep within that maybe 15 minutes, you get up and you go read something. You do something really kind of, not that reading's boring, but read something boring. Something to like just nearly bore yourself to want to go back to sleep again. And there's a lot of like sleep hygiene things as well, like making sure the room temperature is good, making sure it's dark, maybe have a hot shower before you go to bed so to relax the muscles. Those kinds of things can be really helpful if you're one of these folks who do struggle to get to sleep when you get there. So that's a bed restriction. So bedtime, fixing the bedtime, being really consistent with that. And that actually means as well over weekends. So some of us kind of give ourselves a free pass at the weekends to socialize. And obviously that's important. But maybe during that period when you're trying to get back on track, is sort of to be consistent is sort of the message there. And then the other part is that sort of stimulus control. So strategies when you can't sleep, like it's maybe some people, like for myself particularly, I think if I wake up in the night and I start thinking about all the things I have to do, I'm like, I actually, if I can get up and I actually write them down, I used to put them on my phone, but I was like, no more phone. So write them down. And I just like, okay, it's there. I'm not going to forget about it. And I try to go back to sleep. But having these simple techniques, and it might be breathing for some people, and I think that can seem quote unquote boring for some people, but the breathing technique seems to be very, very effective. When you can't sleep, you're almost desperate to try anything, and that's one of the things that can be really effective for people. So just breathing in real slow, almost like counting sheep.
Yeah,
So those are the sort of
fascinating.
the two components that seem to be the most effective, but definitely the behavioural bit around bed restriction seems to be particularly potent, but also maybe the one that's most challenging for people, because you do get up and you're smashed, like pretty tired the next day, and you have to function and do your
Mm.
thing.
Interesting when you say that, because that's a surprise to me a little bit. That the gold standard is try to get 7 to 8 hours or whatever it may be, and then you're saying actually in some individuals it's good to restrict that time for a period of time so that they actually they learn to associate the bed with sleep, and they sleep, I guess, deeper during that
Right.
period.
And it's this kind of whole thing. It's when, and there is lots of data out there around now sleep duration. And I think, you touched on it earlier, that actually can cause a bit of anxiety for people. So they look at their watches now. That's, the watch tells us now you had good sleep or you had bad sleep, but you only, sometimes you feel good after maybe 6.5 hours, but that's because you had good sleep. And when we sleep, our we have like different stages of sleep. And there's one phase of sleep, the deep sleep in particular, that researchers are going after, because they feel like this deep sleep, the longer you can do deep sleep, which we might only get an hour of at night, uh, that if you can prolong the time in deep sleep, you'll have more recovery, next day function. It's better. But if you're waking up several times a night, you disturb where you are in the stages. So every time you have to go back to sleep, you have to start back at stage one, right? And the deep sleep is farther along in the stages. You might never get there, or your time in that stage, it's what they call fragmented, and that's sort of where you could feel a bit more rubbish. Like, my bias to this is that if you can sleep well, if it's less than 7 hours, I think I would, for me personally, I would take that over trying to beat my head over trying to get 7 to 8 hours sleep. If I was sleeping good and I got 6 hours, I'd run with it, and I felt good. I'd be like, yeah, I'll take that.
Yeah, interesting. So one of the strategies that because like sleep interruptions are obviously important, and it's because you kind of start that cycle again of sleep, right? You don't go
Yeah,
back straight into the deep sleep. You have to go through the stages again.
yeah,
One of the things that I ask, because I work in persistent pain, I work at a pain specialty clinic in Robina here. It's a multidisciplinary team with pain specialists, etc. So often this is something that I look at, and one of the things that I've found very useful to reduce interruptions, because a lot of people, especially as they age, they get up more and more to go to the bathroom.
yes, yes,
And so getting them to restrict their water intake later in towards the night. So I usually say, be well hydrated about 3 hours before you go to bed, or 4 hours, something like that. And then don't touch any water. So that way they pass before they go to sleep. And then if we can just reduce one interruption that
yeah,
night, the sleep quality just goes right up.
yeah.
Um, so I found that that's pretty useful. I don't know if that's part of the cognitive behavioral therapy, sleep hygiene stuff.
Yeah, I think it does fall into there, but it's probably underutilized, I think, out there. It's such a great, and like, it makes total sense, and it just avoids that whole waking up and going back to zero again. And you're absolutely right. If you can minimize at least one of those, you're winning, right? You're definitely
Mm.
in the right direction.
So how many people? What percentage of people in the studies actually get improvement from this?
Yeah. So from Sue's work, Sue's McCurry's in the US, she would say that 65% of people would be like, and that when we say get better, we actually mean like almost recovered. So they would no longer meet the definitions of having insomnia, which is pretty remarkable, to be honest. Like, that's pretty good, because even when we try to manage, from your clinical work, when we try to manage pain, it's almost getting it to a point where it's okay, people can live, but it can be there, it will be there, and it's sort of how you manage that expectation, right? So it does seem to be quite effective for a lot of
Yeah.
people. So one of the things that we will do in our work is so we are doing like blood samples, a gamut of things to see at the end of it, can we predict who gets better responses? So also, cognizant that you don't want to waste people's time doing treatments that it might not be for them, and that's totally fine. Like it's not for everyone, and you have to, I think, be in the right space and headspace to do it and commit to do, especially that bed restriction. It's not for everyone, and first of all, we need a better understanding of how these things work, and then we understand how they work better, we can target them better. But some of the groups that would be particularly interested in the studies are, are you going to get, how to say this, like more better? Are you going to get a better response if you've got worse symptoms to start with? Are you the person? We're also going to have a look at sleep apnea. So whether the coexistence of sleep apnea alongside insomnia actually matters for outcomes. And it was really quite interesting. When we started these conversations about designing these studies, we
Come on in. Hello, buddy. How are you?
You say hi?
Hi.
Okay, but now let mommy talk, okay? Good boy. When we have these, the sleep apnea. So when we started out, people were like, oh no, you got to take out people with sleep apnea. It's not going to work. It's not going to work. But then the more psychologists who we spoke to who had used CBT-I were like, no, the effects will be just as good. So we actually have not excluded them from our studies. And then we'll see at the end of it if the results are the same. I suspect that they're going to have more symptoms and problems when they start, like more severity of maybe difficulty with function, maybe mental health challenges. But we'll see if we can nudge the needle for them as well.
Fascinating. Yeah, that's really cool. And is the primary outcome of this research? Is it sleep? Is it pain? Is it what is it that you're looking at?
Really good question. So the trial that we have, so we got two. One is with the US, so the Department of Defense. So the military folks are really interested in this because sleep is obviously a big thing for them. So in that trial, it's pain. And then in the one that we're doing in Australia alone, so we've got a trial that's funded across, we've got 9 different hospitals on board at the moment. So we're trying to upskill the physios in the hospitals to deliver the cognitive behavioural therapy. And we're going to have two primary outcomes for that one, and it will be pain and sleep. Yeah. And the reason we've got the 2 primary outcomes for that trial is because we feel like we'll win even if you just improve sleep and not necessarily pain. Of course, we want to get a better improvement in pain, but sleep is such a massive part of people's life and it matters to patients. Sure. Yeah, we've got sleep included in that one too.
Yeah. No, that's fascinating. How long before we're going to start seeing results on this?
Yeah, so we've started one, Sleep Fit, and it's recruitment from the community in Sydney and in Brisbane. And we've just got about 5 participants in. We just started 3 weeks ago. So we were very excited to get that off the ground. So we are recruitment. And then we've got the other one, which we're going through ethics. So hopefully we'll start recruitment by the end of the year. But honestly, it'll take us about 4 years at least to get some answers, which is painfully slow. But that's the reality.
Yeah, no, that's why I asked the question. I'm like, is it going to be a 5-year horizon? What are we looking at?
Yeah.
In the study, how are you tracking sleep improvements? Are you using biometrics? Is it questionnaires?
Yeah. Such a good question. And we had a lot of argy-bargy about this because the watches, people get fixated, right? And you don't want to spike anxiety and stress. What we went for, we did do the watch, but we won't talk about it, because it's also measuring their physical activity and sedentary behavior as well. And what we will do, like a sub-study within this trial, is to see if we can predict pain flares using these behaviors, 24-hour behaviors, and how maybe well they relate to the recovery of the flare. So that's kind of a side hustle. But yeah, sorry, what was the question?
You're
He's
all good.
walking around in my high heels, this fella.
Yeah. That's so good. That's hilarious. All right.
Sorry, Lachlan.
No, it's good. I think we'll leave all this in there. It'll be entertaining for the people listening. And it brings out the human side. We are not AI generated, Michelle.
No, definitely not. Definitely not. No.
We're the real, authentic, warts and all, kids and all.
Yeah.
No, it's gold. I shouldn't call warts and all. That was harsh.
No.
I love kids.
It could be worse.
Yeah, the question was around whether you're going to use biometrics or more like questionnaires.
So we're using this mattress. So we had actually gone with something called a sleep profiler, but to be honest, when we tested it with our consumers, it was just too involved, to be honest, to get them to do this by themselves. Now, David does use this in his low back pain work in Queensland, but we just felt like to give the people the support that they needed, it was going to be quite challenging. We've actually gone with a mattress, Withering's mattress, I think it is. So it's a sleep mat that you literally pop onto the mattress and you set it and you forget it, but it will get as close as you can without going to lab studies or to, sleep labs to get at sleep apnea. And that's really like, it's going to be very discovery in the sense like there's so many metrics that these equipment can spit out on. Which one is more important clinically, we don't know yet, but we were particularly interested in getting something that could capture the sleep apnea.
Yeah.
Because some of the other, when you go to these labs to get a formal diagnosis of apnea, it's really only over 1-2 nights, and a lot of the criticisms is that's not representative. So having something that can measure continuously for us over the duration of the 1 year that people are in the study it's going to be very, very interesting.
Mm-hmm. Mm-hmm. What's your hypothesis? What do you think is going to happen?
Look, I have to be positive with this. I think that when we manage sleep on top of exercise, it will do better than when we just do exercise or usual physio care. So one trial looks at aerobic exercise, the other trial is usual physio care in the hospitals. And I'm going to be optimistic and say that we will improve pain more so on average. And even if we don't do it on average, there will certainly be people who will get a better response. And hopefully we've got enough granular data to do some really innovative work to find out who they are and why that happened. So we could set hospital systems, physios up better to know who to go, okay, I think you'd respond pretty well to this because of X, Y, and Z.
Fascinating. Yeah. Do you think this will translate to other areas of musculoskeletal pain?
I do. I think it's definitely got the legs for it, and it's something that, we've talked about with shoulder pain, neck pain. You just need to modify things, of course, to the side. But because the principles of how sleep and pain interact, it's not really site dependent, right? It's the pathophysiology of them. So definitely, I think there's scope to broaden it out to not just knees and hips and back. We're quite excited from a nerdy point of view that the trial that we're doing in Australia across the hospitals, that we've set it up as a basket study design. And what that essentially means is that we should be able to answer the question for people with hip pain, people with knee pain, and people with back pain. Because traditionally we put them all together, and you actually need massive numbers of participants to really disentangle whether the effect was different depending on your side of pain. But I don't know, borrowed, plagiarized is the right way, but we've taken this approach from rare cancers. And there's a lady who's working with us from the UK, Bath, in Bath. And yeah, they do these basket designs in rare cancers to answer the questions for specific types of cancers. So this is the approach that we've taken here. And hopefully the idea is that you're more efficient you can get an answer, even though it is going to be 4 or 5 years, but you'll have an answer for 3 different types of the most chronic conditions.
Yeah, that's huge. No, it's really exciting stuff. I think it should translate into good clinical practice and outcomes for people with pain, which is what's so exciting. I kind of get frustrated sometimes with some research because it's so esoteric and like it's not actually going to help the patients in front of me sometimes, or at least it feels that way.
Yeah.
Maybe it will. Maybe it's a launching pad, but this one seems very practical. So yeah, I'm excited to see what the outcome is.
No, thanks, Lachlan. And yeah, we are too. We just have to stick with the and stick with the processes.
Yeah, yeah, yeah. If you were speaking to someone that had crappy sleep and chronic pain, what would your advice be to them?
I would go and talk to the GP about getting some referrals. You know, you can try the apps. There's Sleepio. I'm going to forget them, but there are some apps that you could try maybe before you go to the GP. I'm saying not to go to the GP for drugs. Try your behavior change stuff first, because that's the stuff that outlasts the pills, right? I think very few people really want to take pills or even remember we don't take them even when we are prescribed them, because this is something that really getting on top of your sleep can empower you, and it spills into other aspects of your life, not just pain. But I think you can go in with the expectation, hey, if I manage my sleep, let me just see what it does to my pain experience, and can I get on top of it a little bit more? And know that every night is not going to be perfect. Every night is, the same way every day we show up. It's not perfect, but just be consistent with doing the best that you can and setting yourself up as best you can, and just accepting that, okay, it didn't go right. That's okay. Let's move on. And remember that, when you are in those moments or those periods of flares, when it's particularly bothersome and sore and debilitating, that those moments will pass, those days will pass. And when you get to the other side of it, it will come, right? There will be, you will be okay. And I think that's another opportunity to sort of get on top of these everyday things that we can do, because it's not going to be a one magic pill or bullet. That it's, I think, about consistently showing up, making good choices as we can in terms of our health across our sleep, our movement, our diet, that over time helps us overall.
Yeah, I say this often. I believe strongly that you're one habit change from lasting pain relief. And I really truly believe that. And I think the research is starting to, bolster that, the strength of that statement. But it's such a cool thing that we can not just get short-term relief, but we could actually change the long-term trajectory of these diseases and pain that's associated with them. It's exciting.
Yeah, no, 100%, 100%. I love that. So you're one habit away from long-term pain relief.
Yeah,
I'm gonna think
yeah.
on that today.
Awesome. If people want to learn more about you, stay up to date with the research that you're doing, where should they go to find you?
Yeah, so we have a LinkedIn page that people are very welcome to engage with. It's the Musculoskeletal Research Hub. So it's out of the University of Sydney. So that's where we post most of the work that we do. And
Awesome.
yeah, you feel free to email me, these profiles or whatnot on University of Sydney websites. But very happy to be contacted. And yeah.
Awesome. Awesome. Well, thank you so much for your time. You're obviously a busy young mum with, lots going on, lots of moving parts. Thanks for getting your son to pop his head in at some stage.
Sorry.
No, all good. Thank you so much.
No, thanks so much, Lachlan. I really enjoyed it, and thanks for making it so easy to chat. And yeah, hopefully people find it helpful.
For sure. They will. Appreciate it.
All right, take care.